Welcome to Cancer Conversations with OHC, our monthly discussion with our OHC providers about cancer topics. I'm your host, Joni Monzo. I'm excited today to have Dr. Mark Johns, one of our noted medical oncologists and hematologists. March is colorectal cancer awareness, and Dr. Johns is also our principal investigator for our gastrointestinal as well as our genitourinary cancer research trial. So welcome, Dr. Johns.
Well, thank you for having me.
Yeah, absolutely. When we refer to colorectal cancers, what types of cancers are we actually talking about?
We're talking about cancers of the colon or the rectum, basically the large bowel.
Okay. And I understand that from some of
Prostate and lung, so it's very common. There are about 75 men each year in the U.S. About 75,000 cases in women in the U.S. And that's why screening is so important.
Yeah, absolutely. And we are also reading that the incidence in younger adults is on the rise. Can you discuss the risk factors for colorectal cancer and also
patients are getting colorectal cancer at an increasing rate? And so those things include things like cigarette smoking. So cigarette smokers have about a 50% increased risk of colon cancer compared to those who don't smoke cigarettes. Obesity increases the risk of developing colon cancer by about 20% compared to patients who are fit. And then red meat consumption increases the rate of the developing colon cancer by like 10 to 15%. The magic number is about 100 grams per day, which works out to about 2 ribeye steaks a month. So if you can keep it to that or less, you're probably safe. Otherwise, stick with poultry or fish and you'll be safe.
Good advice. And we know we've often heard about sort of the Greek diet or even the cardiac diet, how those diets really are so good for us in general because they help reduce the risk of a lot of different types of cancer.
Absolutely. So if you could stick to more of the Mediterranean diet and definitely diets that are lower in red meats and lower in processed meats, that would be great for you.
Yeah, good advice. So let's talk about the risk factors that our listeners can't change when it comes to colon cancer.
Yeah, there's several of those. So age, patients who are over age 50 get a higher risk or at increased risk of developing colon cancer. So it's on the decline as in patients over age 50, the incidence, but it's still that's the mainstay of who gets colon cancer. Genetics, you can't change your genetics. So some people are unfortunate and are born with something called FAP. Those patients have about a 90% lifetime risk of developing colon cancer. They develop hundreds of polyps all throughout their colon. They start colonoscopies in their teen years, and it's annual until their gastroenterologist says, I just can't screen this anymore. They have their colon removed. Other patients can develop something called Lynch syndrome or HNPCC. That's probably like 3 or 4% of all colon cancer, and those patients mainly get right-sided colon cancers. And they're not really characterized by hundreds of polyps. It's a very rapid progression from normal colonic mucosa to invasive cancer. And those patients should have a colonoscopy every 1 to 2 years, and they usually start in their 20s or 10 years before the youngest diagnosis of colon cancer in their family.
Okay. And then did we find that colon cancer runs at a higher percentage in certain ethnic groups?
Sure. African Americans, for instance, have about a 20% increased risk of developing colon cancer in comparison to Caucasians.
And do we know why that is?
I don't think we do know why that is, but it's an observation that's been consistent over time, and we just need to know that it is.
Right, absolutely. Is it true, we often hear of some cancers that we think could almost be preventable. Is that the case with colon cancer? Is this a preventable disease?
Sure, with screening we can really minimize the chances of developing a bad outcome. So I'll give you kind of some concepts. If we catch a colon cancer at stage 1, so when it's not very invasive, it hasn't gone in the lymph nodes, we're talking about 5-year survivals that are well in excess of 90%. So 9 out of 10 patients will be alive and disease-free at 5 years and essentially cured of their cancer. And then by the time we get to stage 4, so it's gone somewhere, we flip that whole thing around, and it's now about 9 out of 10 will have succumbed to their disease, and 1 out of 10 will be a 5-year survivor, and then the gradations in between. So it's important to try to catch it at stage 1 or earlier, even better, catch it before it's ever even become an invasive cancer, and that's where screening is so important.
And that's a great segue. Let's talk about screening and colon cancer. So we know that screening guidelines changed a couple years ago. So what is normal consumers, patients at normal risk, what is the recommendation when they should start colon screening?
Sure, so for average risk, it's starting at age 45 now, and then it's colonoscopy every 10 years. And then there is multi-targeted stool DNA testing, Cologuard, and that's every 3 years. And that is an acceptable alternative for patients who are standard risk. It comes with it's convenient, which is its plus side, and its minus side is that if it's positive, you're going to still need a colonoscopy, and there are false positives associated with it, and it does not detect pre-invasive lesions like a polyp as well as a colonoscopy would. So it's good at detecting invasive cancers. It's very sensitive, but not as sensitive for detecting pre-invasive lesions like a polyp.
Good information. And obviously, if patients have a family history, someone under the age of 50 who has colon cancer, whether it's a mother or father or sibling, those conversations need to be had with their primary care physician or
with their gastroenterologist. And typically you're looking at starting about 10 years before the diagnosis in your family.
Okay. So let's start talking about prevention. What are the symptoms, or what should patients be looking for and immediately calling their doctor?
Sure. So the symptoms of colon cancer can be like a change in the caliber of the stool, pencil thin stools, or blood in the stool, abdominal cramping, unintentional weight loss. And then I'm fond of saying the most common symptom is absolutely no symptom at all, and that is why screening is so important. Most patients will present after a screening colonoscopy and they're completely unaware that they had anything wrong at all.
Yeah. And oftentimes people will say, I've had a little bit of blood in my stool, or when I wipe myself, but any blood that is noticed should really be followed up.
Yeah,
Would you agree?
Absolutely, you should follow it up. It's true, though, there's a lot of hemorrhoidal bleeding in the world and in diverticula, but you still want to make sure that you're not the one with a distal rectal cancer that's bleeding and looking bright red, and the only way to know is be evaluated. The peace of mind is well worth it.
Absolutely. So let's talk about, so we've talked about in addition to recommended screenings, what else we can do, and you've talked about plant-based diet, high fiber. Obviously, we always tell our patients at OHC that it's important to share your family history, either with your family doctor, whoever your primary care doctor is. But let's talk about promising treatments, because there have been advances over the course of the last 10 years in treating cancers. What's new with colon cancer treatment, and what's on the horizon?
Sure, thanks. That's another great question. So we have a new trial at OHC that we're very excited about, and it's a trial of a personalized tumor vaccine in patients who have high-risk stage 2 or stage 3 colon cancer. And so, Joni, the way it works is that after a patient has had a colonoscopy and had their surgery, and the surgeon has gotten it all, they tell you, well, it's in a lymph node or two, you're probably going to need chemo. You come to us, and before we ever give that chemo to increase the cure rates, we're going to enroll these patients in a clinical trial if you're eligible, and we're going to draw blood and look to see if there's circulating tumor DNA in the blood. And if there is, then those patients go on to receive standard of care chemotherapy and then are randomized to standard of care observation versus a tumor vaccine. And the tumor vaccine is exciting because it's actually manufactured differently for each individual patient. So the mutations, if you had colon cancer, it would be your individual mutations in your colon cancer would be fed into a computer, and then the computer would spit back out which mutations are most likely to stimulate the immune system. Those mutations would then be turned into an mRNA vaccine, and we feed that back into your bloodstream to stimulate your immune system to recognize your individual cancer and try to clear out any remaining tumor cells. And that's done first weekly, and then every 2 weeks, and then every 6 weeks over the course of a year in an attempt to try to increase cure rates further. What we're hoping for is a positive trial and further increase in the cure rate and an eventual change in the standard of care in America.
That's just amazing.
It is, and so if you or somebody you know has colon cancer and you've been diagnosed and you think you may need chemo, we'd love to hear from you before you get chemo. After you start chemo, you're not eligible for the trial, so it would need to be before then.
Okay, great information and very exciting. Thank you, Dr. Johns. Well, if you want to learn more about OHC's clinical trials, colon cancer, or schedule an appointment with Dr. Johns or get a second opinion, please call us at 888-649-4800 or visit us on ohcare.com. Thank you so much.